And so, FYI, if you have a B12 deficiency, I'm pretty sure you're going to be symptomatic. It might not be this year or next year, but about 10 years, you're probably going to be symptomatic. If you have a folate deficiency, you almost never are symptomatic, all right? So we don't usually pick up folate deficiencies because they're not symptomatic. We pick them up by measuring a folate level. And so I just threw something out to you that I need to make sure you know all about. Iron and B12 and folate, if you ever measure those levels, like a serum iron, serum B12, serum folate level, if somebody's on a multivitamin and has that in it and you check one of those serum levels, the levels are going to be normally elevated. If you ate a really good meal last night, you're going to have a good B12, folate, and probably a good iron level if you had meat last night. So sometimes just measuring a serum level doesn't let you know somebody's got B12 or folate deficiency. Too savvy for your exam, but you need this for your clinical practice. How would you know if somebody had that? If they're eating, and look, there are two other things you can check, an MMA and a homocysteine level. That's what we check in practice when you suspect a B12 or folate deficiency, when the patient has normal B12 or folate levels, right? So here's what you get, an MMA and a homocysteine level, and that will certainly help you with your diagnosis. Once again, I think it's too savvy for your exam, but in clinical practice, you just have to know that. How do we help these people? We give them B12 and folate, and that's how we fix them. The trouble is, if you're B12 deficient, you're going to need replacement for lifetime. If you're folate deficient, we typically give it to you for several months, 1 to 4 months, and then we can tell you to shut it down. All right? So that's really how that goes. I am changing gears. Take a look. A patient exhibits these lesions on his feet. What are these called? Okay, you need these words. You need this vocabulary. Those little dots are called petechiae. And when you have so many petechiae that they make big purple spots, the term we use is purpura. So when you see petechiae and purpura, it means there's bleeding under the skin. Petechiae and purpura are the result of an extravasation of blood under the skin. This patient's bleeding. So I guess the answer to the first question is, what are these called? They're called petechiae. And what usually causes this? Bleeding under the skin. Now, why would you be bleeding under the skin? Maybe because you had, thrombocytopenia, a low platelet count. If you had a low platelet count, you might well have petechiae and purpura. So thrombocytopenia is a term we use if your platelet count is less than 150,000. That's like the cutoff point in every lab in the country. If your platelet count's less than 150, we're going to say you have thrombocytopenia. You don't have to figure out why somebody has thrombocytopenia. Your job is to identify it and know a lot of things can cause it, and some of them are not real good. I'll send them to hematology and let them give them the bad news. Just kidding. Send them to hematology. That's your job, right? All right. And then hematology runs $15,000 worth of tests. And if they run all these tests and they still don't know why, if you just spent $15,000 of your patient's money, you can't look at them and say, I don't know why you got this. What do you say? You have idiopathic thrombocytopenia purpura. You know, we have a little secret language in the medical world, right? And we have all these, so idiopathic. Okay, never mind. All right, so anyway, what's your job? Punt. The cells that swim around in your bloodstream that we have not talked about yet, but we are going to right now, are called leukocytes. Those are white blood cells. And right now, today, if you are healthy, if you're well, the white cell that's present in the greatest quantity are your neutrophils. 60 to 70 of all of the white cells in your body are going to be neutrophils. Another name for neutrophils are segs. Another name is polys. So it doesn't matter whether someone says newt, segs, polys, they're talking about the exact same white blood cell. The one that ought to be present in the greatest quantity if you are well today. The white cell that ought to be present in the second greatest quantity if you are well today are your lymphs. 20 to 25 of all 100 white blood cells, out of every 100 white blood cells, ought to be lymphs. Another 3 to 8 ought to be monos. Another 2 to 4 ought to be eosinophils, and probably there's going to be a basophil swimming around in that 100. That's how white blood cells go. Let's talk about these CBCs and kind of see where you are. Listen, if you interpret CBCs and you know what you're doing and you feel comfortable, keep doing what you're doing. If you're struggling, I'll show you what I do and maybe this will help you. The first thing I do when I get a CBC back is I usually look at my total white count. In this instance, it's 7.9, and I know that that's within normal range. The very next thing I do is go down to my differential, because I want to know what white blood cells they found. So look, go down to your differential. When you look at the differential, the first thing you need to do is add up those white cells. Because if they don't add up to 100, something is wrong with the specimen. Don't waste another second of your time. So listen, I'm looking at polys of, there we go, 10. Okay, yeah, that adds up to 100. It's okay if it adds up to 98 or 102. But it better not add up to 110 or 90. Because if it does, something's wrong with the specimen. You got it? You see that little percent sign after poly, lymph? You see that percent? You know what that means? Part of 100. So your differential has got to add up to 100 or something is wrong with the specimen. So the first thing I do is add it up. Yeah, it's 100. Okay, it's a good specimen. Now what do? Look at the first white cell the lab found. Polys. 46.5, they're low. They didn't find as many polys as they thought they were going to find. All right. What's the next white cell? The lab found lymphs. 43.1, they found more than they thought they were going to find. Well, you just got a huge clue, and here's a clue you should have picked up. Anytime the polys and lymphs are close together numerically, anytime the polys and lymphs are close together numerically, like 43 and 46, always think viral. And I don't think you'll find that in any lab book. But Jeannie, I'm getting ready to write my lab book, and I'm going to put it in my lab book. So what am I thinking? I'm thinking viral. 43 and 46 is viral. What's the next white cell they found? Monos, 10.2. 10.2, Amelie, that's a lot. They found more than they thought they were going to find. What does that mean? Monos are wonderful white blood cells. But you know how they're very different than polys and lymphs? The monos don't come out to help for at least 24 hours. So if the monos are elevated, what does it tell you about how long the patient has been sick? Greater than 24 hours. So with elevated monos, infection greater than 24 hours. Which brings us back to our polys and lymphs, and here's what you ought to know. The polys and lymphs are your first responders. Within 2 hours of your getting sick, the polys and lymphs are going up or down depending on what kind of infection you have. So polys and lymphs are your first responders. The monos come out after 24 hours. What else did the lab find in my patient's bloodstream? Eosinophils, 0.1. Oh, that's normal. Good. If it had been elevated, what two common conditions produce elevations in eosinophils? One is allergic reactions, and the second one is parasitic infections. So the two most common conditions associated with elevations in eosinophils are allergic reactions and parasitic infections. Here's a normal, good. Basophils, 0.1, normal, good. So what am I thinking already? I'm thinking it must be viral based on my polys and lymphs, and I'm thinking greater than 24 hours. After I know that, the next thing I do is go back up, and now I'm going to get my red cell indices. The first thing I want to know is my patient anemic? What three things do I look at? RBC count, hemoglobin, and crit. What are you thinking? The hemoglobin and crit are both low. This patient's anemic. The next question you have to ask is, what kind of anemia do they have, Amelie? You look at the MCV, 70.4. What word comes to mind? Microcytic. You got to look at the MCH, the color. What word should come to mind with that number? Hypochromic, right? So this patient's anemic, all right. They've got microcytic and hypochromic red cells. You with me? So they have a microcytic hypochromic anemia. Right now, what's in your differential? Iron deficiency anemia and maybe thalassemia. I don't know for sure which one it is, but I know which one is not. Look at the RDW. Oh, it's elevated. They're not all the same size, so it cannot be thalassemia. It's probably iron deficiency anemia, right? My money's on iron deficiency anemia, but I don't know that until I get iron studies. You with me? So what do I know from looking at this string of numbers? I know that the patient's got a microcytic hypochromic anemia. I know it is not thalassemia because the RDW is elevated. I know that they've got a viral infection that's greater than 24 hours in duration. Do you see it? That's a lot to pick up from that string of numbers. Everybody got it? Let's keep going. Look at this one. Total white count, 15.9. That's elevated. There are a lot of white cells swimming around in this patient. Let me go to my differential. First thing is it adds up to 100. Good. Poly's 81. Wow, that's a lot. Lymphs, 2. 2? The difference between 81 and 2 numerically. It's big. Amelie's brain says, think bacterial. I'm thinking of a bacterial infection. What do the monos tell me? 14.9, they're elevated. How long has this patient been sick? Greater than 24 hours. So bacterial greater than 24 hours. EOs are good. Wait, bands? What are bands again? Immature white blood cells. Amelie, I thought you told me the bone marrow was like really smart and it was like always on patrol. It never took a vacation. Why is the bone marrow letting out these immature white blood cells? They're not supposed to be in the bloodstream. They're supposed to stay in the bone marrow until they're mature and ready to go. Here's why. The bone marrow is on patrol. Oh my God, look at that horrible infection. Polys and lymphs, go quick. And it sends out the polys and lymphs, and man, it's looking, oh man, they need help. They're getting killed. Come on, monos, you got to go. When do the monos come out? After 24 hours. After 24 hours, finally the monos go out. And the bone marrow's looking, man, they're still getting killed. They need help. Bands. You pitiful, but you the best I got, bands. You got to go. So now the bands go out. So when you see bands, it means the bone marrow thinks it's bad, right? That's what it means. And does it tell you the difference between viral and bacterial? Nope. It just lets you know the bone marrow thinks it's bad. So bacterial greater than 24 hours, bone marrow thinks it's bad. Go back up now and get your red cell indices. First question, is my patient anemic? RBC count, oh yeah, they're anemic. What do the red cells look like in my anemic patient? What word comes to mind with an elevated MCV? Macrocytic, big. MCH, normal. So it's a macrocytic normochromic anemia. What two should be in your differential? B12 and folate, right? So I don't know, I need some more tests, but those two for sure in my differential. Everybody with me? All right, so bacterial greater than 24 hours, bone marrow thinks it's bad, macrocytic normochromic anemia, B12 and folate in my differential. Here's the last one. Total white count 6.2, good, it's normal. Differential adds up to 100. Polys and lymphs, whoa! 90 and 8. Numerically, those two numbers are far apart. What's Amelie's brain thinking? Bacterial. Well, wait a minute. If this was bacterial, I would have expected my total white count to be higher. At least on the upper end of normal. It's only 6.2. Here's my very best hematology pearl. Patients should look like their blood work. When patients don't look like their blood work, you've got to get more information, which might mean more historical information, more information in the line of a test or on a physical assessment. You've got to get more information. So it's looking bacterial. Suppose the patient tells you this story, Amelie, and it's 8 o'clock in the morning, they're your first patient. They'll say, Amelie, when I went to bed last night, I felt fine. But at 5:30 this morning, I woke up, I got a razor blade sore throat. I can't even swallow my own saliva. And suppose they have strep throat. If their labs look like that, does that look like the patient? Yeah. How long does it take your total white count to rise? That doesn't happen right away. So if they just got sick, the first responders, the first ones that move are your polys and lymphs, and they did. But the total white count is not going to go up for another 12 to 24 hours. And the monos are not even there. The monos are still in their bone marrow. You got it? So patients should look like their blood work. So that's one possibility. It could be an early clinical infection. But maybe this patient's immunocompromised and they're not going to mount a big old white count. You with me? That's certainly a possibility. Whew. Oh, Amelie. All right, you ready? Take a big, deep breath. Take a look. What lab test probably should not be ordered if a patient is taking an iron supplement daily for anemia? It's a recall question. What was it? Don't order a serum iron level. If they're taking iron by mouth, you're not going to order a serum iron level. It's going to be normal or elevated, and it's not going to give you any valuable piece of information. You got it? All right. What diagnosis, next question, what diagnosis is most likely in this patient? All right, so let's take a look. RBC 3.5, that's low. Hemoglobin low. Crit low. We have an anemic patient. MCV 72, MCH low. So we have a microcytic hypochromic anemia. You agree? The peripheral smear. Remember, the med tech tells you what the red cells look like. Says the patient's got microcytic hypochromic red cells. I'm going to give you a little hint. I want you to look at the RDW. It's normal. What do you think could be going on with this patient? A thalassemia is a really good guess. If you were really savvy, you would say, Amelie, it could be 2. It could be thalassemia, but it could also be iron deficiency anemia of long standing, right? Maybe. What would I expect you to answer if you weren't taking the exam? Thalassemia, all right? So number 2 is probably your best answer. Look at this one. A patient has recently developed iron deficiency anemia and is taking iron supplements. What is his serum iron level likely to be? You got a serum iron level and they're taking supplements. What are you thinking? Elevated, right? So taking iron supplements and the iron level going to be elevated. Circle number 1, increased. Everybody got it? And I think this is your last one. Take a look. A patient is found to have a mixed anemia. Oh, what does that mean again? More than one anemia present at the same time. It's iron deficiency and B12. What might his MCV most likely be? Oh, Lord, Amelie, I have no idea. Think about it. Think, critically think. If they have an iron deficiency anemia, they got a microcytic red cells. If they have B12, they're macrocytic. Little and big average out to normal. What might the MCV be? Normal. Oh, Amelie, that was a trick. Circle number 1. That's a tough one.